Hi, this is Bob Harrington from Stanford University. I have the privilege of being the chair of the Heart of Cardiology conference that we'll be hosting on Medscape Cardiology and theheart.org in December. As a prelude to that, we've been having a series of conversations with colleagues who will be leading some of the program content in December. And today I am pleased and privileged to be joined by Dr. Guillermo Expires from Emory, where he is a professor of medicine, and he is also the president-elect of the ADA. So Guillermo, thank you for joining me here on Medscape Cardiology.
Thank you. Thank you much, Bob. Looking forward to a very interesting meeting.
Well, the session that you're going to lead, I think, has some of the hottest data in cardiology, and that is thinking about in diabetes, some of the new drug therapies like the SGLT2 inhibitors, the GLP-1, but also then starting to get into some of the real key questions like what is the role of our thinking about the kidney and renal disease? What is the role of obesity in both its impact, but also its treatments? So let's start with some of the hot data. And maybe one of the areas that's most exciting for cardiologists is the data that's emerged for SGLT2 inhibitors. We first saw that data in type 2 diabetes, but we also see it now in not just patients with atherosclerosis, but patients with heart failure. We see it even some benefits of the SGLT2 inhibitors without diabetes. Do you want to try to piece together the story for us? You know, what are we using these drugs for? And did the whole finding of their benefit without diabetes surprise you?
Yeah. And well, let me get back to a couple of decades ago. So the treatment of type 2 diabetes has evolved from the 1980s to about 2000, 2005. We followed the results of the United Kingdom prospective diabetes studies, the diabetes complication control studies, that shows that reducing hemoglobin A1C reduces the risk of microvascular complications. So decrease retinopathy, nephropathy, amputations, and somehow improve cardiovascular outcome. In the year 2000, 2008, 2015, we conducted several studies trying to improve hemoglobin A1C or improve glycemic control and reduce cardiovascular disease, and they all failed using the traditional agents, the metformin, the sulfonylurea, the DPP-4. They didn't really help us much in reducing cardiovascular disease, knowing that cardiovascular disease accounts for 60 to 80% of mortality in patients with diabetes. So in the last 5 years, now we have several trials, as you mentioned, using SGLT2s and GLP-1 receptor agonists, and they have shown to improve cardiovascular and renal outcome. So in particular, the SGLT2s are oral agents that they work by increasing glucose excretion in the urine. So it produces glycosuria and also produce natriuresis. And that resulted in lower blood pressure. And if you lose calories because you lose glucose in the urine, well, you also lose weight. And these agents have been shown to reduce major cardiovascular outcome, acute MI, cardiovascular death, and stroke. So, and there are several studies now that have shown that also improve the renal outcome. So slow down the progression of kidney disease, even in patients who already have nephropathy. In addition, perhaps the major effect in cardiovascular outcome is in heart failure. All of these agents, there are 4 now in the market, have shown to reduce risk of heart failure admission, especially in those patients who has reduced ejection fraction, but about 30%. And in those patients, they also reduce mortality. So there is no question that the use of these new agents like SGLT2s, they have really changed the way we approach the treatment of patients with type 2 diabetes. And you also mentioned that there has been approved, especially DAPA, for patients with reduced ejection fraction with heart failure, even in patients without diabetes. So they are commonly used now. They're usually given once a day, oral, And it can be given in patients with or without increased blood glucose, especially in those patients who have cardiovascular disease and heart failure.
Yeah, boy, that was a fantastic multi-decade summary of a lot of important data, and I look forward to the discussion in December. You know, it's interesting, the FDA requirement now years ago of requiring clinical outcome studies for new diabetes agent was really a very important part of all of this, because it forced us to do these large outcomes trial. And I think you've summarized it beautifully. You talked a little bit about the effect of SGLT2 inhibitors in the patient with kidney disease. I'm going to come back to that, but let's talk about GLP-1 and obesity. That to me has also been an interesting story of you're now starting to see people use GLP-1 to treat obesity as a mechanism of potentially not just weight loss, but of decreasing cardiovascular risk. You want to talk a little bit about that?
Yep. And GLP-1 receptor agonists, what they do is increase the endogenous production of GLP-1, and hormone that have been shown to increase insulin secretion, decrease glucagon, and decrease appetite, increase satiety. So patients who are getting GLP-1 eat less, and therefore they tend to lose weight. And because it's independent of, and it's the ability to reduce glucose levels, it depends on how low or high is the blood glucose. They are not associated with hypoglycemia. So you can use GLP-1 in patients with or without diabetes. And because it decreases appetite and increased satiety, has been shown to reduce body weight. They also slow down gastric emptying. So your food in your stomach that usually goes away in a couple of hours will stay there. So therefore you eat less. Similar to SGLT2s, have been shown to have reduced in MACE, in major cardiovascular outcome, have also had some renal protection. And at the dose to treat patients with diabetes, they produce body weight loss of about 1 to 3 to 5 kilograms. But there are now studies with high doses of these GLP-1 receptor agonists, where the weight loss can go all the way up to 5, 10, 15% of body weight. And the recent study with semaglutide were published in the New England Journal of Medicine, so that you can lose about 50% of patients lose about 10 kilograms, but even more, about 25% would lose about 15 kilograms. So you're talking about similar to gastric surgery. So I think that but these are not for doses to treat diabetes. These are high doses that are guided to treat obesity. Why are they used in clinical practice? Yes. Unfortunately, they are very expensive medications. We still have some issues with coverage, but therefore, the data is very clear. These agents are very effective in producing weight loss, in addition to have the cardiovascular and the renal protection effect.
Yeah, I mean, you made reference to the New England Journal articles. I'm now seeing patients who are bringing me those New England Journal articles who don't have diabetes and say, is this something I should try for weight loss? Who are you using them in for weight loss without diabetes?
Well, we have an obesity center, and we offer this patient lifestyle intervention. I mean, about 1/3 of the patient lose weight, about 5%, 7, 10% of body weight with lifestyle intervention. The problem is that you have to do it for the rest of your life. So that's why most long-term success of lifestyle intervention, diet and exercise is not what we want it to be. So there are several medications that are available for weight loss. And now we have, we mentioned the SGLT2 minor weight loss of 1 to 3 kilograms, but the GLP-1 in high doses are very effective. So depends on insurance coverage. Some patients are able to get these new medications, and you get liraglutide 3 milligrams or semaglutide 1 daily. I mean, you can achieve significant weight loss. And in the pipeline, there are new medicines who are even more effective than the current GLP-1 alone.
Yeah, and you mentioned that that these are results which are similar to bariatric surgery. One of the things I think that's intrigued me, and certainly I think has been of interest to the broader community, is the relationship between bariatric surgery and improving cardiometabolic health, even before you lose a lot of weight. Why is that?
And very, very likely is that the weight loss, you're going to see it within in a matter of a few weeks to a few months. But the effects of all of these agents with weight loss, it maybe is related to fatty liver deposition, ectopic fat depositions. It usually goes away much rapidly that you will see weight loss. So I think it's the toxic effects of fat in different tissues, perhaps mediating all of these effects.
Yeah, it's really interesting, isn't it? I mean, now you're starting to think about cardiometabolic health as having even broader issues with regard to human health. You mentioned fatty liver and NASH, and NASH has now become the leading cause of chronic liver disease and the need for transplantation. It's pretty impressive as people lose weight, as their diabetes gets under better control, that NASH seems to be is a reversible condition, isn't it?
Yeah, and you're right. If you lose, is a patient with type 2 diabetes, especially if they have diabetes for less than 8 to 10 years, if they lose 10 kilograms or 10% of body weight, about 50% are able to stop medications. If they lose 15% of body weight, about 75% are able to stop medicine, and the fatty liver deposition goes away. Even before you get the major effects on cardiovascular outcome, you're going to see that NASH goes away. The fat deposition in the liver is seen in about 60% of patients with type 2, but most of them are obese or overweight. And it's seen in a large number of obese patients, more than 50%. And just losing 5 to 10 kilos is the best way to treat fatty liver deposition of fat in the liver.
Yeah, I mean, it's pretty impressive. The other disease that I have read about lately and talked to my heart failure colleagues is HFpEF, heart failure preserved ejection fraction, as at least one subtype of it, typically that associated with diabetes and obesity, is also being a metabolic disease. You want to comment on that? Are you seeing those kinds of patients whose presentation of a cardiac condition is not necessarily atherosclerotic disease, but in fact is heart failure due to their metabolic derangements? In addition to atherosclerotic disease and fatty liver, we also hear people from the heart failure community talking about HFpEF, heart failure with preserved ejection fraction, at least one phenotype of it being that amongst patients with diabetes and obesity. Do you want to comment on that? Are you seeing patients who are presenting with heart failure, with their diabetes, with their obesity, that actually gets better as we treat their metabolic diseases?
And yes, and there's no question. And also the use of certain medication associated with weight loss has a significant impact, reducing the risk of heart failure. SGLT2s are the #1 medication that is recommended by the American Diabetes Association, independent of glycemic control, to be used in patients with heart failure. Now, I think they are more effective in the low ejection fraction, but in the preserved ejection fraction, there's also some indirect data, some direct and some randomized control trials that they may help. Same thing with the GLP-1 that produce significant weight loss and also had been shown to reduce the risk of heart failure readmissions in these patients. So I'm not going to tell a cardiologist about the preserved ejection fraction, how to manage these patients in a way that is so controversial. But there is no question that improving weight loss will have a direct impact on cardiovascular outcomes.
I'm okay if you tell the cardiologist about that, because it's an important thing that we should all know about. So thank you for sharing that. Let me end with a question about health equity. That we're seeing an increased incidence of diabetes, of its associated manifestation of kidney disease and cardiovascular disease amongst groups, Blacks, Hispanics, that diabetes having a higher incidence, obesity in some populations having a higher incidence, and the ramifications of all of that being atherosclerotic outcomes like myocardial infarction, strokes, etc. Comments, maybe this is an appropriate time to ask about your ADA role
Yeah.
and comments from the broader view that you have as the president-elect of what we can all do to be thinking about the health equity question in the cardiometabolic space.
And health equity, the ADA is one of the major initiatives that we have had during the past couple of years. And I'm very much involved in this program because we know that health inequalities have been shown to increase the risk of diabetes and diabetes complications. And social determinants of health are really related to health equity. So we have economic or financial reasons, food, relative decrease or type of food that patients are able to get, housing. There are several factors that impact on diabetes control. So for example, the other thing is access to medications. That's right. We have a large number of patients who do not have insurance with this, a very high and high cost of medications, where about 1/4 of the patients taking insulin have to stretch the insulin, do not take all the insulin they need to because of the high cost of the medications. You're talking about GLP-1, where the cost, and you don't have insurance, is well over $400 or $500 per month, which is almost impossible for a lot of our patients to get. So what we are proposing with the ADA is that every time we see a patient with diabetes, you have to go over the social determinant of health. Do the patient have access to this medicine? How can you help these patients? Do the patient have food insecurity or not? With minorities patients, at least in downtown Atlanta, 30 to 40% of our patients have food insecurity. So if you don't know how you're going to eat at the end of the month or what you're going to do, how are you going to adjust your medicine? So the health equity issue in diabetes is not only with the complications, but even with the number of patients with diabetes is an extremely important point that we need to address as a community. That's right, as a whole.
You've really summarized the key issues, and certainly from the American Heart Association perspective, we share with you the focus on the social determinants of health, and we're pleased to be part of USAE as the community of trying to help address some of these issues for our patients. So I look forward to the December conversation on that particular topic. Dr. Expires, this has been a fantastic conversation about the types of topics we'll be addressing at the Heart of Cardiology conference in December. Thank you for joining me here today on Medscape Cardiology and theheart.org.
Well, thank you, Bob, for this opportunity, and we look forward to be with you in December.